Dr. Somsekhar Bijal, Honorary Secretary, IPSKC, to welcome the gathering. Somsekhar, sir. Bijal, sir, are you there? Okay, I think some network issues. We'll go ahead. I welcome today's chairperson, Dr. Girish Babu, sir. He is Professor of Psychiatry at SDM Medical College, Harvard. And I request him to take over the session and introduce the speaker and go ahead with the scientific deliberations.
Thank you, Bhimsen. At the outset, I would welcome all the postgraduates and trainees who have joined the program. Basically, it's an innovative program on psychotherapy. And to begin with, I am happy to introduce Dr. Jayant Mahadevan. He has completed his MBBS, MD, and MD psychiatry from JIPMA, followed by completed his DNB, and then he has done his DM in de-addiction in NIMHANS. Currently working as assistant professor at Center for Addiction Medicine, NIMHANS. He has many publications in national and international journals, and also has won many awards to his credit. And so I would hand over the presentation to Dr. Jayant to present on motivation enhancement therapy.
Thank you so much, Dr. Girish. So at the very outset, I would just like to thank the organizers, IPS Karnataka chapter, for having kindly invited me to talk to all of you today. And of course, thank you, Dr. Girish, for a very warm introduction. I'm just going to go ahead and share my screen.
Yeah.
My screen is visible, right?
Yeah.
Okay. So I'm Dr. Jayant Mahadevan, Assistant Professor, Center for Addiction Medicine, Department of Psychiatry and Finance. So let's dive straight into talking about motivation enhancement therapy. So motivation enhancement therapy is a systematic intervention approach which is based on the principles of motivational psychology. And it is designed to produce rapid, internally motivated change. We'll talk a little bit more about that in the slides to come. It's important for us to recognize what motivation enhancement therapy is not. So motivation enhancement therapy is very different from typical confrontational approaches, where the emphasis is usually placed upon helping people or making people with addiction understand that they have a problem. And only if they understand that there is a problem, then they can actually go ahead addressing it. These are directive confrontational approaches on the one hand. On the other hand, you have what are called non-directed or client-centered and Rogerian approaches. So MET is quite different from these approaches as well, because primarily in client-centered or non-directive approaches, the direction which is taken in terms of how the therapy progresses is wholly and solely by the client or by the patient himself. Right? In contrast to these two polar opposites, motivation enhancement therapy could probably better be understood as a guiding approach. So in motivation enhancement therapy, it is a directive approach. So it is not a non-directive approach, it is a directive approach. However, it is a client-centered approach, which respects the autonomy and other important factors about the client. But there is a willful move by the therapist to actually guide patients towards positive behavioral change. And that is the fundamental tenet of motivation enhancement therapy. So there has to be a willful guiding towards positive behavioral change. So it is interesting to understand what the origins of motivation enhancement therapy are. And if one looks at the traditional conceptualization of people with addiction, probably in the 1950s, 60s, and 70s, generally what it was understood is that people with addiction are inherently people who, as a patient characteristic, are people with higher levels of denial and resistance. And so the idea was that psychotherapy for patients with addiction required that you had to break down that resistance. You had to kind of work through the denial. And so people felt, and this included approaches like psychodynamic approaches, which were used at that point of time. And the idea was that you used to have long-term therapies for them to be able to actually benefit and get better as such, right? So come the 1980s, we talk about William Miller and Stephen Rolnick. We'll be talking a lot more about them in the slides to come. And they were pioneers in the field of motivation interviewing and motivational enhancement therapy. And so they wanted to look at things in a slightly different way. So what they tried to do was, they felt that it was probably not a patient attribute, but probably an attribute of the therapeutic interaction, which leads to a great amount of resistance in patients with substance use disorders. And so what they decided to do is they systematically studied this relationship and tried to see what was its relationship to outcomes in patients with substance use disorders. And what they found, of course, was very interesting. They found that direct persuasion or a very directive approach in these patients elicited resistance and led to negative outcomes, but an empathic approach, which enhanced motivation, led to positive outcomes. Another interesting piece of information which came around the same time was that there was a lot of research which pointed towards very few differences in outcome between these traditional, longer, intensive treatment programs and shorter, less intensive, brief approaches that were noted to be present. And so it was in this context or in this matrix that motivation enhancement therapy was born. So motivation enhancement therapy, as we all know, is primarily delivered as an individual therapy. Although, and this is there even in the MET manual, family members or a significant other can also be involved. More recently, MI or MET based interventions have also been developed in couple and group formats, but we're not going to be talking much about that here today. The settings for MET can be either outpatient or inpatient. The duration of any kind of MI or MET intervention is a brief 2 to 4 sessions of 1 hour each. So it is not a very long, elaborate intervention. And one of the good qualities of the MI intervention is that it can actually be combined with other treatments such as CBT or 12-step facilitation. So obviously here we are going to be talking primarily about the application of MET in the treatment of alcohol and drug use disorders. And that is where most of this literature started from. So Miller and Rolnick, their initial work with MI and then subsequently in the development of MET was for treating people with problematic alcohol use. But over the past 30 or 40 years, there has been a large body of literature, over 2,000 publications, which have looked at its applications in various other kinds of disorders, including behavioral addictions, eating disorders, anxiety disorders, and a lot of literature in the field of behavioral change in non-communicable disorders, diseases like diabetes and hypertension and so on. And there is a reasonable amount of evidence which supports their use for behavioral change in these contexts. So with this understanding of what motivation enhancement therapy is, I think it's important for us to now get into a little bit more of detail to be able to understand what are some of the fundamental tenets which underlie motivation enhancement therapy. The first thing that we're going to talk about in this context is something that is called the Transtheoretical model of change. So this was something that was given by Prochaska and De Clemente. They came up with this model by conducting a study amongst smokers and seeing how smokers both in and out of treatment underwent change in their smoking behaviors. And then subsequently after that, of course, they've generalized their model to change in general, how people change in general. And so they've talked about various stages of change, starting with pre-contemplation, where the person does not feel the need to change, moving on to contemplation, where the person is ambivalent or unsure about whether he or she should change, moving on to preparation or determination, where the person has already started making steps towards changing their behavior, action, where the person has actually implemented behavior change already. Maintenance is essentially maintenance of the action phase for a period of 3 to 6 months. and relapse is considered to be return to the previous pattern of behavior. So now the transtheoretical model of change is important in the context of MET because it is essentially the backbone or the framework of MET, because MET essentially tries to make people move through these stages of change. The second thing that we are going to be talking about is motivational interviewing. You would have heard me using the terms MI and MET interchangeably, but they're actually different things. Motivational interviewing was something that which was given by William Miller and Stephen Rolnick, and they've written 3 books, very successful books about it. In 1991, second edition in 2002, and the latest edition in 2011. And motivational interviewing is a collaborative conversation style, which is used for strengthening a person's own motivation as well as commitment to change. So motivational interviewing essentially is the technique that is used in MET. So MET is essentially an application of motivational interviewing. There are other applications of motivational interviewing as well, but probably MET is one of the most commonly used therapies in which the conversation style of motivational interviewing is used. And most of the principles of MET in that sense overlap with MI. And so for the rest of this presentation, we are going to be basically focusing a little bit on understanding the various elements of motivational interviewing. So there are 3 things that we need to focus on in this context. One is what is called the spirit of motivational interviewing. The second is the principles of motivational interviewing. And the third are the skills that are involved in motivational interviewing. We'll start off with the spirit of motivational interviewing and how this came about. So when Miller and Rolnick wrote the first edition of their book in 1991, obviously they were more preoccupied with the skills required for MI as well as the principles of MI. But over a period of years, when research had accumulated, they were able to find out that there is something more than just skills and principles which governed whether MI was successful or not, or the outcomes related to MI. And this is what was designated the spirit of MI. And it is understood with the acronym of PACE, standing for partnership or collaboration. And so essentially what that means is in MI, it is a partnership between the therapist or the doctor and the client or the patient. There is a spirit of acceptance. And what acceptance means is a way to be able to actually recognize the inherent worth in the patient or the client, to respect the person's autonomy, to be able to understand the context from which the patient comes. And that is done using accurate empathy. This is a term which was originally given by Carl Rogers. And also about being able to affirm what are the good qualities within your patient or your client. The third aspect of the spirit of MI is compassion. And the fourth aspect is what is called evocation. And evocation essentially means that it is a recognition that people inherently have the ability or the motivation to change. And the spirit of MI just says that the job of the therapist is to evoke this change. So this is something which gives us an overall gestalt or an idea about what MI stands for or what it represents. And it is seen to have a great bearing on how the application of MI takes place. Next, we move on to the principles of motivational interviewing. And when we talk about the principles of MI, again, the nice thing about MI is that each of these things have acronyms for us to remember things better. And so the acronym that is used for the principles of MI is called DARES. And it stands for developing discrepancy, avoid argumentation, rolling with resistance, express empathy, and support self-efficacy. So we will talk a little bit briefly about each one of these principles, starting with the development of discrepancy. So this is probably one of the most important principles of MI, because MI is based on the fundamental tenet that a discrepancy between the person's present behavior and what are important goals in that person's life is what will be a fundamental motivator of change, right? So when the person is able to recognize that there is a discrepancy between where he is and where he wants to be, that is when change tends to occur. Right? So this is important because the primary goal of the therapist in the context of MI is to be able to develop this discrepancy. Right? So how does, just very simply, how is this actually done? One thing that needs to be done is one needs to raise awareness regarding consequences of the person's present behavior. And this can be done in a host of ways. One is just by talking to the person and interviewing him in a certain way, the skills about which we will talk about later. It could include doing structured assessments. It could include doing blood tests to be able to identify the consequences of the present behavior, to be able to raise awareness within the person about the consequences of the behavior. Then subsequently after that, one wants to understand what the personal goals of this person are, and then guide the person towards being able to create a discrepancy between what's happening right now, the present behavior, and the person's future goals. We'll talk a little bit more about this in the skills section of our presentation a little further down. So probably the one of the most important aspects of MI, principles of MI, is to develop discrepancy. The second principle is to avoid argumentation. And this is fairly self-explanatory. Obviously, what one needs to understand is in the context of MI, arguments are probably more likely to generate a rift in the therapeutic alliance, as well as more resistance, which tends to occur. And that will bring us to the next principle of MI, which is rolling with resistance. Now, this is again something which is very unique to motivational interviewing, because resistance is a concept that you will hear about many times in the upcoming psychotherapy lecture series that you guys are going to have, because resistance is a term which comes up in various psychotherapies and it has different connotations in different psychotherapies. How it is understood in MI is actually very interesting, and it's a nice way of understanding resistance. So first, we need to understand what is resistance. And so resistance can manifest in various different ways. So it can be the person arguing, denying that the problem exists, interrupting the doctor or the therapist, or ignoring or sidetracking whatever that the therapist is trying to say. So the difference of how resistance is understood in MI is that people understand resistance not as a patient characteristic, but as a characteristic of the therapeutic interaction. And it points the therapist in a direction to say that, look, this is a signal that you are not going on the right track. You need to respond differently. And that is where the whole concept of rolling with resistance or not opposing resistance. So the example which is given is a very nice one. It is about rolling with resistance is like dancing rather than wrestling. So when you are wrestling, you are essentially trying to pin the person down into submission, right? Whereas when you are dancing, you are kind of gliding past resistance when you face it, right? And so one example of this is something like when a patient says or a client says, I will not stop drinking. So then the therapist or the interviewer might turn around and say, okay, by the time we are through with this session, you may decide that it's not worth the effort to quit. It's tough to do so, but that decision is entirely yours. So essentially, you're not meeting the resistance head on there. You're not saying, okay, no, but why should you not stop drinking? Drinking has caused so much harm to you. You've said that, okay, I recognize that you don't want to stop drinking. You may or may not change that decision, but then ultimately that decision is up to you. We'll see how it goes from there. So this is what is called rolling with resistance. There are also other responses which are used for resistance or resistance or not wanting to change as such. These can include reflective responses wherein one can offer reflections. We'll talk a little bit about reflections later. The other kinds of strategic responses which can be there for dealing with the resistance in the context of MI include things like emphasizing autonomy, reframing, agreeing with the person but with a twist, or coming alongside. So these are a few examples. So say, for example, when we're talking about autonomy or emphasizing autonomy, person says, I don't want to exercise. And the therapist says, it's certainly your choice. No one can make you do it if you don't want. Right? Reframing is another very important component of being able to roll with resistance. So, for example, if a person says, my wife is always nagging me about my drinking, one way of looking at it would be looking at it from a negative light. Another way of reframing it would be where the therapist says, oh, if she's nagging you that much, then she must really care about you. So it's to help people to be able to look at things which prevent change in a different light. That is what is called reframing. Similarly, when we're talking about agreeing but with a twist, patient says, I cannot imagine myself not smoking. It's a part of who I am, part of everything that I do. So the interviewer emphatically says, you just wouldn't be you without it. It's so important that you may just have to keep on smoking no matter what the cost. So essentially, you're trying to elicit some kind of a response from the person. You're saying that, yeah, I know smoking is important to you no matter what the cost of it may be. And this may actually be a gentle way to be able to deal with the resistance in this concept. The final two principles that we'll be talking about are the expression of empathy and supporting self-efficacy. Empathy, again, in the context of motivational interviewing, is understood as a specifiable, learnable skill for understanding the meaning in another person's life, and it utilizes the principles or the skills of reflective listening, and basically requires sharp attention to everything that the patient says, and a generation of hypotheses in our head as to what the underlying meaning of what the person would be saying is. Right? And so that is how you demonstrate or express empathy in the context of motivational interviewing. The final principle of motivational interviewing is supporting self-efficacy. And essentially what this means is that the client's belief in the possibility of change, as well as the counselor's own belief in the person's ability to change, are important motivators in the ability for the person to actually change. So therefore, supporting hope, optimism, and the feasibility of accomplishing change can help to bring out the client's strengths. And so when we try to support self-efficacy, what we try to do is we talk about how the client has achieved things in the past, tell them that it's about taking things one day at a time. And these are ways in which one can support self-efficacy. Now, finally, moving on to the skills of motivational interviewing. Again, there is a helpful acronym for this, which is called CORES. The core skills of motivational interviewing are open-ended questions, which are basically just questions, and most of you would already know about this. They are questions which are difficult to answer with just a brief reply or a simple yes or no. They are essentially conversational door openers, and they encourage the patient or the client to talk. Affirmations are statements that recognize the client's strengths and acknowledge behaviors that lead to positive change. And essentially what that means is that when you're talking to the person, you try to point out, selectively affirm those behaviors that the person has done, which point towards change. And that is where I was saying that MI and MET are a very, very thought out, willful way to be able to nudge a person towards change. So you selectively affirm statements. So like say, for example, if the person has agreed to come and speak to you, although he's reluctant about his giving up his drinking, you may say something like, I appreciate that you're willing to come and talk to me. So that is, you're recognizing some of the strengths and motivating the person towards moving towards repeating behaviors which the person finds as desirable. So you can say something like, you've handled yourself really well in that particular situation. Okay? So these are affirmatory statements which can be there, which can motivate or nudge the person towards change. The other probably very important skill of motivational interviewing is reflective listening. So reflective listening is where the therapist listens to stated and unstated, so not just stated, but also unstated thoughts, feelings, and meanings, and reflects them back to the patient. And this helps the patient understand that the therapist is listening and understanding. So it is something which is very, very important, because this could be a way in which you can actually encounter a lot of problematic communication that actually occurs. So when you're talking to a person, the person doesn't know whether you're actually understanding what you're saying or not, unless you actually use something called reflection. And so there are various types of reflections that are there. A simple reflection would be just restating what the person says. The person says something, you just restate it back, simply reflect it back to them. And that could be a way of helping them to understand that you are listening. There are also specific types of reflections which can be which can be utilized to amplify ambivalence, to develop discrepancy. So for example, double-sided reflections are reflections which are used to capture both sides of ambivalence. So suppose a person is unsure about making a change. You use a double-sided reflection to be able to tell the person that they are contemplating change. So essentially, what the person is doing when you do reflection, what is happening is that the person is actually listening to his own thoughts told back to him. And so he is able to kind of process it better at that point. Amplified reflections are another strategy which are used, wherein you are actually exaggerating the negative aspects of one particular thing that the person has said. So you exaggerate the disagreement or the feeling or perception that the person is having with them at that point. The final skill of MI that we're going to talk about is summarizing. And summarizing is a very, very important skill in the context of motivational interviewing. It can be used at various times. It can be used in the middle of the interview or middle of the intervention. It can be used at the end of the intervention. And essentially, again, it is something that the therapist willfully does. So it is not, a summary is not just a repetition of everything that the client has said. So it is essentially a set of statements or inferences that the therapist presents to the patient at the end of the session or during the session. And the idea is it takes some skill to be able to summarize. You want to actually summarize in such a way that you nudge the person and pick points towards change rather than points towards staying the same. So it's essentially you kind of nudge the balance towards the person wanting to change through your summaries. And essentially what you do is you summarize and then you ask the person, okay, did what I tell you make sense? So it helps the person to be able to understand that you have understood everything that the patient has said. And it also offers the patient to add any additional information at this point. Okay, so based on this, and these are the skills that we've talked about. There are essentially two phases of MI, depending on which edition of the book that you read. The first phase is what is called building motivation for change, and the second phase is what is called strengthening commitment to change. And so when we talk about building motivation for change, there are three processes that are involved in it. Those include engaging, which is essentially the initial part wherein you settle into a conversation with the client. Focusing, which is kind of finding the direction. So you want to move towards the direction which you are trying to target. And evoking, which is eliciting the client's own good reasons for change. And that's what we'll talk about in the last 2 or 3 slides. Following this stage where the motivation for change has been built up, the second phase of motivational interviewing is strengthening the commitment to change, wherein you actually develop a plan, guide them through a plan to change. So linking up MI and the transtheoretical model of change, one needs to understand that based on which stage of change the patient comes to you, there are different kinds of tasks that you have as a doctor or a therapist. So when a person is in pre-contemplation, obviously what you want to do is you just want to give feedback, raise doubts, increase the client's perceptions of the risks and problems with the current behavior. That's all that you can hope to achieve in the context of a person in pre-contemplation. In a person who is already ambivalent, you want to make sure that you tip the decisional balance towards change, evoke reasons for change, highlight risks of not changing, and strengthen the client's own ability or self-efficacy for that change. When it comes to a preparation stage, you want to help the client to determine what is the best course of action to take as far as seeking change and develop a plan. In patients who are already in the action phase, you want to help the client implement a plan, use these skills, problem solve, and support self-efficacy. And in the context of maintenance, essentially, you want to identify and use strategies that will prevent relapse. If the person relapses, you want the person to get back to the stages of contemplation, preparation, and action, and not become stuck or demoralized because of the relapse. So the final part of my presentation is probably the most important, because this is essentially what we do to be able to elicit change talk in patients in the context of MI or ME. So there are various ways in which change talk can be elicited. One can be by the use of feedback or the use of provocative or evocative questions as such. So what you need to do in that context is elicit the harms the patient himself has experienced by the use of assessment, providing a feedback of negative consequences, and then subsequently after that elicit what would you wish to do? What could you do to change this? Why would you want to change this? What do you think needs to be done? So these are the kinds of statements or questions that can be put forward to be able to elicit or bring forward change. Another very common technique that is used to elicit change talk is what is called a decisional balance. And that is essentially an exercise wherein you tell people to list the benefits of changes, benefits of changing and the benefits of not changing, and the consequences of changing and the consequences of not changing. And this can be used as a visual kind of reminder to help people elicit or come out with reasons for change. Another very popular strategy which I particularly like to use is what is called the readiness ruler. And what you do in this context is, when you're talking about change, you ask how important is change to you on a scale of 0 to 10, where 0 is not at all important and 10 is extremely important. I mean, change is extremely important for you. So then the patient may say that I am at a stage, I feel that my stage is number 6. I mean, like, I feel the number 6 as far as how important it is for me to change. So the idea then would be to follow it up with a question wherein you say, why did you choose 6? Why did you not choose a lower number? Why did you not choose 2 or 3? So then the patient may turn around and say, look, 2 or 3 is very low. I'm more interested in changing. I think it's more important for me. So that you're eliciting self-motivational statements or change talk from the person. And another way to elicit change talk is, okay, you have said 6. How do you make 6 into 9? What would it take for you to make it into that? And then the person is actually talking about things that the person can do to move forward from the stage that he's at currently to a better stage. There are some of the other strategies as well to elicit change talk. So there are basically, this is a set of options that you could use. You can say things like, suppose you continue on as you have been without changing. What do you imagine are the worst things that could happen? Similarly, what do you think would be the best results if you did make this change? And this could be ways of being able to elicit change talk. Another way is to be able to either look back or look forward. What are the differences between the person you were 10 years ago and the person you are today? Tell me how you would like things to turn out for you in 5 years or so. So this is something which I like to use a lot as well, looking forward. When your usual decisional balancing and evocative questions are not able to evoke change talk, this would be a good strategy which you can use to be able to actually find out where do you want your life to be in another few years. That could be a way to ask people to be able to come up with statements which encourage change. So once you've been able to elicit these statements, you need to consolidate it. And what you can use is something called a change plan worksheet. So this is an example of that. The changes that I want to make are X, Y, Z. Most reasons I want to change are this. The steps I plan to take in making this change are what some things that could interfere with my plan are. I will know if my plan is working. So this is a change plan worksheet which can be. So in summary, motivational enhancement therapy is a direct approach to behavioral change. It is based on the change. It uses principles and techniques of motivational interviewing to bring about change. And in practice, it is often used to build patients' motivation and combined with other therapies such as relapse prevention therapy. Thank you very much. And I'd like to just end with this quote, which says, if you treat an individual as he is, he will stay as he is. But if you treat him as he were what he ought to be and could be, he will become what he ought to be and could. That is probably one of the basic principles of motivational interviewing. Thank you.
Thank you, Jayant. It was a very simple and lucid presentation on motivational enhancement therapy, and I think you have highlighted the importance of the process, where some of the important principles what we need to know, followed by the skill sets, and the key of the principle. I mean the motivational interviewing, the primary aspects of it, and I think. As a psychiatrist or a mental health professional, all of us should have some principles of it, which is useful in our routine clinical case management apart from addiction. I think we also look to use it when we are trying to enhance compliance in patients with schizophrenia and these conditions. Okay, now with this, I think there are a few hands being raised. So let's move on to question and answer session. I think yes, Akanksha has a question. You can unmute yourself and ask the question. Okay, let's start with Dr. Bhimsen, the question that motivational interviewing can be subjective. So how do you find the skills like these useful?
Thank you, Dr. Bhimsen. So I have actually utilized, this is the University of Rhode Island Change Assessment Scale, Eureka. I have not used it in a clinical context, to be very honest. It is something which has been utilized primarily in research contexts, where people want to be able to look at motivation as a factor which can influence outcomes, I mean, substance use outcomes per se. I mean, clinically speaking, I think most often the assessment of motivation is something which is just done by asking the person questions about whether they want to change or not, and then follow-up questions about why they want to change. What is it that makes them want to change? What are the factors which are influencing them? And then based on that, a judgment is taken as to which stage of motivation they are at.
Yeah, Nishi, you have a question. Please, you can go ahead with the question. You can unmute and ask questions, or even type in the chat box, or even question answers box. Motivated to quit one substance but not other one.
I wish I could ask Roopsi this question. So the idea is, again, so if you go by the principles of MET, and that's where we need to start from ultimately, which is that you have to determine which stage of motivation the person is at a given point of time. And you have to work on interventions for those particular stages of motivation. So say for example, a person is motivated to stop using alcohol, but is not motivated to stop using tobacco, for example. That's the simplest example that I can take. So what you would want to do is the interventions which would be appropriate for somebody who's in the preparation stage for alcohol would be what you would do for alcohol. Whereas what you would want to do for people who are in a pre-contemplation stage for tobacco would be to increase their awareness about the risks of tobacco, to be able to help them to move from probably pre-contemplation to a contemplation stage where they're thinking about change. You can't obviously move them directly from pre-contemplation stage to a preparation or an action stage straight away. So for each substance, you would have to do what you do for depending on which stage of motivation the person is at.
So is motivational interviewing different for behavioral addiction? I mean, that's the question which is there. Shashi Gupta has asked. So again, as I said, coming back to the idea is that this can be used for any sort of behavioral change. So the idea is it's not specific to alcohol or tobacco or
I mean, have tried it and tested it in different conditions, and they may have different levels of evidence or efficacy in different conditions. But the core fundamental tenets remain the same, which is that you start off with being able to help the person recognize that there is a discrepancy between the way that the behavior is currently occurring and where he or she wants the behavior to be, and sustain or help the person to be able to build the motivation to be able to change the person's behavior. So whether that is gambling, whether that is internet use, whether that is alcohol use, the contexts are just different, but the principles are exactly the same.
Yeah, so we have a question on how many days does it take for change from one stage to other?
Oh, it's a very, very nice question, I think. So again, it depends on where you actually meet the patient. So when we talked about the various processes that are there, essentially you start off with engagement, then you move on to focusing, then you move on to evoking, and then subsequently on to planning. So when you're talking about building motivation for change, it is going to determine how do you actually determine whether the person is actually motivated to change. You will only be able to judge that based on the person's responses. When the person is making less statements which point towards remaining the same. So for example, if the number of times the person is talking about not wanting to change comes down, there is more statements which the person is making which point towards the fact that I want to do something about this. That means that you're moving towards a stage where the initial phase of treatment is kind of getting over. Now, there is no definitive thing. So if you look at the literature, some people say within one session, people move from contemplation to preparation. And there are other people who say that it takes many sessions to move from pre-contemplation or contemplation to determination and action. So it's difficult to be able to judge that in terms of exactly how long it is going to take. But the idea for us as a therapist or as a doctor is to be able to recognize where the person is at, and the interventions need to be provided accordingly. If we try to jump ahead, then the person tends to move back.
Yeah. There's one question by Dr. Beni. Can motivation therapy be used in patients with dissociation where there is a lot of dynamics in life?
So I'm not sure about whether it can be used in people with dissociative disorders. Logically, I don't think it would. I mean, because again, dissociation, the idea behind dissociation is different, right? There are unresolved conflicts which are there, which usually present as physical symptoms. But if you're talking about enhancing motivation to be able to be in therapy, that is something which can probably. So that's the nice thing about MI. Essentially, it can be used with any therapy to be able to enhance compliance or enhance motivation to remain in a particular treatment. So that could be something which could be considered.
There's one question by Dr. Akansha. How different will MI be in presence of comorbid personality disorders like ASPD?
Okay, so once again, I'm going to keep coming back to this point again and again, and that's really where I believe that if you have to be a reasonably successful therapist who uses MI principles and uses MET, you are going to have to stick on to that spirit of MI which I'm talking about, which is that ultimately you are going to have to say that you're going to work as partners collaboratively with the person. You're going to respect the person's autonomy. You're going to be compassionate, and you're going to try to tell that, yes, the person has the ability to change, really. Now, I want to ask you in terms of, are you talking about change of substance use in the context of ASPD, or is it the change of ASPD related behaviors? Again, I'm going to talk about the context of substance use, because let's not go into antisocial behaviors per se, because again, it may not be very relevant in this context. So you can continue to utilize the same principles even if there is a personality disorder present in the context of substance use, with the understanding that the whatever the person is saying, you're going to believe. If the person says that he ultimately wants to do something about his drinking, that means he wants to do something about his drinking. Just because he's ASP doesn't mean that we should not believe that he wants to do something about his drinking or his smoking or so on, right? So from our perspective, we need to go with what the patient says and follow through with that.
So this question about what percentage of unmotivated individuals change to motivation, after MI.
So I'll talk a little bit about the research that has been done and that would help to probably answer this question. So essentially what you want to look at in this context is not only the change in motivation. So there are 2 or 3 outcomes. One is, of course, does substance use come down in the context of motivation enhancement therapy, even in patients who are relatively less motivated. And so it's primarily targeted towards patients like that only. So there has been evidence that there has been reduction in substance use, which is seen particularly in the context of alcohol. Alcohol is where there is the most data that is available. And so there is improvement with regards to that. There is also seen to be improvements with regards to retention and treatment. And retention and treatment overall is something which is seen to improve outcomes in substance use disorders. So I think that is the way that one would need to look at it.
Do we have any numbers in terms of percentage who have changed with MET? That is what I think
Yeah. So I'm also not sure. So I will have to get back to you with regards to that.
So when should a therapist take a decision to stop therapy because there is no result?
Mm-hmm. So again, it depends on what you define as no result, right? So and that again is something which is very, very important in the context of any sort of intervention for substance use. So if we say that the only outcome that we are looking for is the person is abstinent or not, right? Then you will get disheartened very, very soon, right? So the idea is, if a person is not willing to stop drinking and you want to make them stop drinking immediately, that is not probably going to happen. You will get, and this is something that is, when you read the books on MI, essentially they talk about something called a writing reflex. And then the writing reflex is essentially something which is there amongst us as helping professionals, that we want to make people better in whatever way it is possible, however we understand what being better is in that way, right? But ultimately, the onus of change is going to have to be with the person. So the idea, there is no end to this.